next up we have the wonderful Erin Mills. Erin is the paediatric emergency physician at Monash Health. She's also the quality lead of emergency services. And her fun fact is that she was once in a Bollywood movie. She's going to be talking about how to host an M&M meeting without making anyone cry. Take it off, Erin.
Great. Thanks, Grace. So I get palpitations when I think about some of the M&M meetings I went to as a junior doctor. Everyone would file into the room. The front row was reserved for the most senior doctors. They usually came in late, 5 minutes late, holding their lattes. Middle of the room was the registrar levels, and then the interns and medical students were right up the back. And then scattered throughout were a smattering of nurse leadership if they had time to attend. I'd sit in the corner with my fingers and toes crossed that none of my patients were going to appear up on that screen, and I wasn't going to get publicly humiliated for a mistake that I didn't even know that I'd made. The cases would get presented. The most senior doctor in the room would cast their judgment. Often someone would get blamed for what went wrong. No one dared to disagree with that senior doctor in the room. And then we'd all walk out afterwards, and quite often the junior team needed to have a cup of tea or a coffee to debrief. Obviously, things have changed, and I hope that M&Ms aren't run like that anymore. But there are certain elements of the M&M, of how it was run back then, that are still happening today, and that's what I'm going to talk to you about. I'm going to give you some key principles to use when you're attending or facilitating a mortality and morbidity meeting to give you the best chance at improving care for the next patient that comes along, because that's the goal of the M&M. And along the way, I'm going to hopefully give you a couple of ideas about how you might practically implement some safety 2 principles, like we were talking about before, at the first session, into your teams at a local level. Because it's really important that we look after our staff, because looking after our staff is also going to mean that we're looking after our patients. So, like I said, the goal of a mortality and morbidity meeting is to learn from what went wrong and change it so that it doesn't happen again. But like Beck was saying, it's actually even more important to learn from those near misses, because what we want to know is what could go wrong so that we can change something so that no harm actually occurs to our patients. And we're not going to find out about those near misses, we being leadership or quality oversight or the person facilitating the M&M, unless since COVID we're called frontline staff, but those patient-facing clinicians that are actually doing the day-to-day work looking after patients. Those, we are the people that know where the risks are to patients in our system. And we're only going to come forward and tell people about those risks if 2 things happen. Firstly, we'll come forward if we feel like we're going to be listened to. If we keep complaining about risks and risks to our patients and risks to our colleagues, but nobody listens and nothing changes, we're not going to keep coming forward. We need to know that we're listened to, changes happen, and then those changes are fed back to us so we know that the process was worth our time. The second thing that we need to make sure that our staff are going to come forward and tell us where our risks are in the system is that they need to feel safe. And staff are not going to feel safe to talk about risks if they feel like they're going to be individually punished or blamed when something goes wrong. If I administer, or one of my friends administers a wrong dose of a medication, and I spend the 10 plus minutes trying to fill out a risk man to report that, and the result of that is that I'm made to redo my mandatory training modules of how to administer a medication correctly, I'm not going to report that incident again, am I? And so the organisation is going to be blind to the risk. When something goes wrong, 2 parties are accountable. The individual, yes, you have to come to work, fit to work, with the knowledge and skills to be able to do the job you're employed to do. That's your job. The organisation has to provide a system for you to be able to provide high quality, safe patient care. And more often when something goes wrong, there's a problem from the organisational level with that system than a problem on the individual level. And that's what we need to focus on. If I give a wrong dose of a drug to a patient and that patient is harmed, Two things have happened. Either I've woken up that morning and I've said, I'm going to hurt someone today, and I've deliberately drawn up that wrong dose of the drug and I've injected it into the patient knowing that that's going to cause them harm. Cases like that are vanishingly rare. They're not dealt with through our M&M or incident review processes. They're dealt with disciplinary actions and sometimes through the judicial system. Way more likely is I've come to work in healthcare because I care about people, I'm a kind person, I want to help people, and I'm doing the very best job that I can, and I am mortified that I'm at the end of that syringe that has caused harm to that patient. When we're talking about when something's gone wrong, it's really important to put yourself in the shoes of that person at the end of the syringe and say, what circumstances were they working in that has led to that problem occurring? Were they a grad nurse who wasn't supervised? Were they working their third double shift that week because the department's so short-staffed and they're exhausted and not concentrating? Did the EMR crash and the usual processes for being able to check that drug dose didn't work? Correcting any of these things is way more likely to prevent that error happening to the next patient than punishing whoever was pushing that medication in. So these people might be familiar to some of you in the room, especially those from the UK. They're pictures from the media. On the left is a little boy named Jack Adcock. He died in 2011 of Group A strep sepsis, which is a disease that strikes fear into the heart of paediatricians. He'd presented to a UK health service and deteriorated and died later that day. An absolute tragedy. The person on the right is the registrar that was looking after him that day. Her name's Dr. Hazita Bawagaba. And in what I personally see as another tragedy to come out of this is she was struck off from the medical registrar, banned from working, and she was also convicted in a criminal court of manslaughter for causing the death of little Jack Adcock. So I'm going to talk through just a few facts about the case, which hopefully will reinforce to all of us that punishing an individual staff member is not going to prevent something like this happening again to another patient like Jack. Luckily, the good news of this story is everyone else was as outraged as I was to hear about this, and Dr. Bawagaba is back at work and her criminal conviction has been overturned. But it took a couple of years. So Jack presented with his mum to the ED one morning. He had a history of Down syndrome and he'd come in with vomiting, diarrhoea and some respiratory problems. He was seen by Dr. Bawagaba in the emergency department. She admitted him. She ordered some tests, including some blood tests. Now, she'd just returned from maternity leave. She'd never worked in that health system before, in that specific hospital, and she was still getting used to the layout and the processes there. The other registrar was sick that day and they couldn't find cover, so she was covering the job of both registrars and had a lot of patients across a lot of wards. Her consultant was off-site and so supervising remotely. There were significant nursing staff shortages that day too, which meant that Jack didn't have as many vital signs recorded as he perhaps should have, and his deterioration was delayed in being recognised and wasn't escalated to Dr. Bawagaba or any of the rest of the team as early as it perhaps could have been. The pathology IT system crashed that day, and the blood results that might have given an early clue that Jack had sepsis and treatment could have been started a little bit earlier, but the pathology system crashed and the results weren't available for more than 5 hours, way longer than is normal. And finally, Dr. Bawagaba had rounded on the paediatric ward that day. She'd rounded on a little boy who was not for resuscitation in one of the cubicles. Jack was moved up from the ED into that patient's bed bay, and at the end of the day, when the resus buzzer went off after Jack had arrested, Dr. Bawagaba arrived with the rest of the resuscitation team and was confused. She thought Jack was the patient that was not for resuscitation and actually suggested that the resus team stand down. Took a couple of minutes before the mix-up was noticed. The resuscitation was recommenced, but unfortunately he didn't survive. So this is a either complicated or complex case. I can't remember which one it is, but it's one of them. And this is a framework which is based off the London Protocol, which is one way we can think about complex cases, but we can also apply exactly this to simple cases to try and work out what contributed to this tragedy happening. And you'll see that right in the middle is Jack and Dr. Bawagaba. Right in the middle there is the staff member and the patient, and it's extremely rare that you can find something that you can improve at these levels that's going to have a big impact on a large number of patients. In this case, Jack had a devastating disease, group A strep sepsis, really high mortality rate. We can't change that unless we invent a vaccine. Please invent a vaccine, someone. From a staff point of view, Dr. Bawagaba was a senior registrar. She had the skills and knowledge to be able to look after Jack. Perhaps, and I'm just guessing here, she was tired because she'd returned back from maternity leave, but we can't really fix that either. But what we can do is look outside there. We can look at the team, and quite often we'll find problems with communication within or between teams. We'll find issues with handover. In this case, there was delayed escalation to medical and more senior medical staff, and there was possibly a lack of supervision from senior staff into the care of Jack. Then we look outside, the work environment. This is the layout of the room, the layout of the ward. You know, would a clearly labelled patient name outside the door have helped in this case? We talk about staffing here too, so critical medical and nursing understaffing both contributed here as well. And then going out further, on the organisational level, this is where we think about our processes and our policies. And here's where I think, you know, is there a better way that our code teams could identify which patients are for or not for resuscitation? Is there a better way that we could orientate staff returning from long periods of leave, such as maternity leave, and support them on their return to work? Across most layers of task and tech, and obviously the pathology system crashing that day was a contributor, and so we've got to think, have we got a good workaround process for when that inevitably happens again? Outside are bigger issues that are usually outside the scope of individual health services to be able to address. But I think you can see here that putting one doctor in jail or preventing her from ever working in that health system again isn't going to change any of these other problems that led to the death of little Jack Adcock. And in fact, it might distract teams from being able to identify these problems, and they'll continue to cause harm to future patients. So, moving on to language. We talked a little bit about language this morning and the concept of the never event and whether or not that is a useful concept. A couple of other simple changes in language. We could talk about incident reviews instead of incident investigations. We could talk about adverse events instead of incidents. It's just a less punitive, more open, more inquisitive terminology that can help. Leadership, like any cultural change, and that includes safety culture, is really critical. And you are all the leaders in the room. In our place, we have senior clinicians sit down and have lessons learned discussions with the junior staff, because we've all been involved in patient care that we wish we'd done differently. When something bad has happened and we've learned from that and something has changed as a result, and sitting down with our junior staff and telling them about what happened, firstly prevents them making the same mistakes that we made before, but also normalises this process of talking about when things go wrong and thinking about ways we can improve and change our practice. The second worst thing after that phone call saying, remember that patient you saw last week, is your patient popping up on the screen in an M&M meeting and you having no idea. Really, really important that the core care team is aware that the patient is going to be discussed and that they have the opportunity to participate in that discussion. In our paediatric ED, we have a resus review process where every paediatric resuscitation is reviewed by the team It's kind of an asynchronous debrief. We sent out an email to everyone who is involved from all disciplines at all levels of seniority and say, what went well, what didn't go so well, and what do you think we could do to make this situation better in future? And everyone in the team knows that all of these are discussed at M&M and they're told the date, and they have the opportunity to participate verbally in the M&M if they like, but also all the feedback that they give, and we get a lot of feedback as a result of these emails that guides the discussion and the actions that we take out of our M&M meetings too. I wish I didn't have to say this, but M&Ms aren't a medical-only affair. I know that in some places they still are. I really hope that's not in any of your places. Healthcare is a team sport. Each member, junior, senior, medical, nursing, allied health, play therapy, security, the patients and their family bring their perspectives and ideas to how we might improve the processes. And like Ben said this morning, the people working in the teams know how to make it better, and M&M is a great place to be able to listen to that. In our emergency department, we traditionally had senior medical staff leading our M&Ms and presenting all the cases. We changed that up a bit and we asked some nursing staff to present some cases. We asked junior medical staff to present some cases, and we actually found that we got an increase in attendance from both of those populations, but even better, an increase in actual participation in the discussions happening on the day because they felt more welcome to contribute. My favourite topic. Most of the time we do things really well. Humans are amazing at being able to adapt to really complex situations like healthcare is, and still giving our patients the very best outcomes. We adapt to surges in patient number and acuity. We adapt when the EMR goes down. We adapt when a pandemic happens, and we change and we continue to provide great care, and almost all of the time we provide excellent care to our patients. It's really important that we acknowledge that, and like has been said earlier today, that we learn from what goes right. I see Rob Roseby in the audience who facilitates some of these at our health service, have awesome and amazing meetings. So these are where we think about cases where things went really well, and we dig down into why they went really well and how can we replicate that for all of the other patients. In our emergency departments, we have a compliments box where staff can compliment each other for providing fabulous support to their colleagues, but also fabulous care to the patients. You know, for example, Dr. Bob did a great job in diagnosing appendicitis in a toddler who had autism and was significantly speech delayed, who'd presented quite atypically. And he did that because he really listened to the mum who said, I know something is wrong, and then he got a play therapist down which helped facilitate a great examination and get him the blood tests, and the patient had a really good outcome. Compliments like those are shared with the whole team, so everybody knows what a great job Dr. Bob did, and we also send them up to more senior leadership within the hospital so that everyone knows what a great job we're doing actually on the ground in our emergency departments. So, as you go from here, firstly I hope you're all attending your M&Ms at your relevant departments because your voice matters and you know where the problems are, and we all want to hear about them so we can make care better for future patients. I want you to think about your language and your actions next time you're at or facilitating an M&M meeting. I want you to use safe language. Remove surprise elements. I want you to think about the system and the system factors that led to that event happening, and remove any individual blame. Try and promote representation and engagement for a variety of disciplines, and maybe that means you could have a case presenter that's outside the usual SMS or other model that you use. And finally, how can you celebrate success? Could you add an awesome and amazing case to your next M&M? Could you set up a compliments box? I just used an old tissue box and covered it in pink paper when we first started and popped that on the staff desk. Staff loved popping compliments in about each other, and I loved reading them. because we can learn as much from what goes right as we can from what goes wrong, and it's much more pleasant. Thank you.
Thank you very much, Erin. We probably have time for a quick question.
Thanks very much for that, Erin. I really enjoyed your talk. My name's Emma. I'm a nurse in Adelaide, and the disclaimer is I'm doing a PhD on M&Ms and paediatric acute care. So I'll chat to you after. I'm almost at the end. But I wanted to thank you for amplifying that point around including the whole team and really just kind of draw attention to the fact that it is more than attendance, and some of the positive discrimination strategies that you've used around alternating presenters and getting an agenda from the outset that can take away the pressure within the room itself, I think is a really important thing to draw attention to. One thing I wanted to seek your opinion on is how we communicate with consumers about M&M meetings, and how when systems and process issues potentially are identified that didn't necessarily change a patient outcome, where open disclosure sits within this space and how you feel the future could look with communicating to parents about what's actually happened in the case of care.
Yeah, thank you. I'm glad you agree with some of my points with all your expertise, so that's a relief. Yeah, I really think that we should be able to include patients and consumers better. They're currently, in Victoria, we've got this new process called a statutory duty of candour, where it's really made much easier because it's legislated to engage patients and their families in more serious adverse event review process. But the M&Ms seem to be more lower level incidents undergoing a review process, and there's not, we don't currently have a strategy in our departments, open to anyone else, of how to involve the patient and family in these processes. The standard kind of rules of open disclosure, when something goes wrong, you know, I'm really sorry that this has happened, this is what's happened, and this is what we're going to do about it. But we currently don't formally get the view of patients and families when we're reviewing cases that are in M&M. Where the next phase of our resuscitation review process is to get input from patients and families about their perspectives of the resuscitation, because their priorities are quite possibly going to be quite different to what ours are, but the whole point of healthcare is about the patients and their families, so possibly they're more important than ours. But a really good point, and I did touch on that they are definitely part of the healthcare team, but they're currently not attending or involved in M&M processes.